Good evening, everyone. Welcome to this EUSOMII 2025-2026 monthly webinar series focused on the application of AI across radiological subspecialties. Each webinar will be jointly organized by EUSOMII together with a relevant subspecialty society with the aim to promote interdisciplinary dialogue and foster collaboration within the radiology and AI community. In each webinar, there are two speakers, one from EUSOMII who will discuss a technical aspect, and another speaker from European Society who will discuss a clinical application of AI. Today is the time of AI in breast imaging, jointly organized with the European Society of Breast Imaging. In this webinar, we explore how AI is transforming breast imaging and clinical practice. Each presentation will last approximately 20 minutes, and both presentations will be followed question and answer session. You can write down your question at any time using the box in the chat, and we will read the questions at the end of both presentations. I remind you that this session will be recorded and shared on both societies' website. Let's start the record. And I am ฤta Pecchi. I am an associate professor at Modena University, and I am honored to moderate this webinar with Pinar Yilmaz. Please, Pinar.
Thank you very much, ฤta. I'm also very honored to moderate this webinar together with you and to host this with our guests, Matthias and Paola. I'm Pinar Yilmaz from Erasmus Medical Center. I'm a resident in radiology and nuclear medicine, and I'm also the vice president of the Young Club Society within EUSOMII. And then I will really want to introduce Professor Matthias Dietzel as our first speaker. He is a professor of radiology at the Department of Radiology, University Hospital Erlangen and 𝗏𝗏𝐼⁴ Erlangen-Nuremberg in Germany. He specialized in diagnostic radiology, and his scientific focus is on breast imaging, artificial intelligence in medical imaging, and evidence-based medicine. Professor Dietzel is also an editor-in-chief of the European Journal of Radiology, Artificial Intelligence, and he is the deputy editor-in-chief of the European Journal of Radiology. Matthias, the floor is yours.
Thank you so much. Thank you so much, Pinar, and I hope my screen is visible now. Yeah, looks like that. Thank you very much, and thank you everyone for inviting me here to speak here at this session. It's really a pleasure and honor, particularly to do it together with Paola, who is a fellow EUSOMIAN friend. So I'm already excited for the discussion. I think this will be a wonderful opportunity later on to discuss these hot topics. I think this will be fantastic. So thank you very much for having me here. And I always like to start with a little smile on my edge, the conflict of interest, which will also kind of outline my talk. So this is me in the early days, a bit more hairs, but some things did not really change that. So I'm an academic radiologist. This is why I'm starting with a technical perspective, and Paola will really infuse the most relevant clinical stuff. So this is really my background and still one of my focuses. I'm a breast imaging enthusiast, and I've been risen by this guy in the background. This is Werner Kaiser, and he taught me, still as a medical student and as a resident and as a PhD, many things. And one of the things he taught us, this is Pascal Palzer, with him Paola is working together in Vienna, and I worked together many years ago. And this is obviously me here. And he taught me, Werner, to always to critically think, to ask questions, to go underneath the umbrella and really discuss the stuff in detail. And this is also what I would like to do today a bit more, because I think we are now in breast imaging and breast imaging AI in a phase where we already are ready to fly, but there are still a lot of discussions, a lot of questions to be asked. And I think it's our obligation as clinicians, as academic radiologists, as as radiologists in general to ask these questions, to solve these problems before we basically rise our airplane into the air and make the full use of AI. Because this is what I'm convinced, once we got on the track, once we got out of the sky, then I think it will be difficult to fix problems. So this is why I will the focus put a little bit under the critical things and discuss stuff. This is something which by my career is a little bit unusual. And this is why I also switched focus in the last years more on the editorial stuff, because I love overseeing clinical papers, academic papers, and I would like to share some of my insights I collected here during the last years. And last, but certainly not least, I'm a really enthusiastic EUSOMIan and also EUSOBIan, so I'm happy to speak here in a sort of, if you wish, hybrid role. And these are the two journals I'm involved with. Well, let's start first. My talk actually is technical aspects. What is actually technology? You may expect me to talk about algorithms, to talk about software, hardware, and this kind of stuff, but everyone who knows me, spoiler, I'm not a coder. This is not what I want to talk about. What is actually technology about? And we here at the EUSOMII, we know this very much. We have fantastic PhDs who can talk about this for hours. And many of these talks are on our YouTube channel, which I invite you to revisit. What is a technology actually definition? Well, it's actually application of knowledge to achieve practical goals in a reproducible way. So this is what Wikipedia tells us, and I think we can use this as a nice seeding point and a red thread for my talk. It's really about knowledge, it's really about data, and it's also about reproducibility, and it's always around practical goals, clinical goals. And I think it's extremely important to have that insight, because we shouldn't just start and play around with our AI tools, buy the latest stuff. It should always be focused to our clinical need. And this is why technology also has, beyond algorithm, beyond software and hardware, also another topic, which is data, obviously, which is validation, which is workflow itself, human interaction, governance, and last but not least, responsibility. So this is why I would like to start my technical talk with some stuff which I'm super certain Paola will highlight later on in way more detail. And this is really what the needs of AI are, because technology without a clear need is useless. There are tons of papers on that, and I know most of you won't be breast imagers, but if you want to start a talk like that, we really have to talk about critical research gap and translational priorities. And this is a nice, wonderful article which on a scientific level really summarizes these goals. And these are still valid. And these 7 research gaps, evidence-based research gaps, are the essential outlines of this paper. And 3 of them are certainly most related to imaging, which already shows you how important AI is from a technological and clinical aspect in breast imaging. This is super important. I only will touch base at selected one of these. This is a special issue in our journal where we, together with a lot of authors from the global breast imaging community, collected insights about that. Let's briefly touch base, not to go too much into detail, but just to show you why it's so important to select this and which technical aspects, which technical challenges may be deducted from that. So breast cancer screening obviously is in the center of AI application and breast imaging. This will certainly be also one of the hot topics of the later discussion. Why? Because it is, detects breast cancer early, and it reduces the mortality and improves obviously outcomes. We all know this. And AI can support this in many technical ways. AI only, AI triage, AI plus radiologist. And there are some papers out there which we will discuss later. One of that is certainly the Maasai trial, a randomized control, population-based trial. Just a short spoiler. If you want to do a deep dive, check the EUSOBI social media channel, where the first author gives a nice introduction on that. The key bottom line of this paper is use of AI in mammography is safe. And this is top-notch scientific data. Technology-wise, this seems to work, but there's more than just one large study. There's more than the 𝗲𝗂 trial. There's obviously the Screen Trust trial, a huge trial, 55K women have been investigated. And the key bottom line is that we have a reading with AI plus radiologist a 4% higher non-inferior cancer detection rate. This is just quickly in a super quick nutshell what we are currently dealing when we're talking about the needs. But what is beyond that? What can the technology achieve beyond that? Well, first, obviously, risk stratification is one of the stuff we should and must discuss in this context, so we can tailor the treatment pathway, the management pathway to the individualized patient need. This sounds like future. It certainly is in many scenarios, but in breast cancer, it certainly already has a huge and a long tradition. So which traditional risk models can we use for that? Well, there are certainly many. One of that is a trilacusic model, but they are based on very limited number of factors, but they are not applicable to all women. They do have calibration challenges, and most of all, the predictive power is rather, I have to stress that, moderate. And this is important because we want to assess risk, we want to assess and calibrate the treatment for the individual patient. So this is a wonderful use case for AI. And one of the landmark papers on this is shown here on that slide. I do not want to go here into details and want to know you guys what this is about. The key conclusion, however, should be clear that all AI tested in this wonderful paper outperformed traditional risk models. And this is now a stage where we should go one level deeper and do a deep dive and ask important questions, assess technically what's going on here and whether the future is really that bright. And let's look at the cancer risk of the model. So if we go into the clinical model, you have it here. I highlight it for you because the table may be a little bit busy after a long day. 61 performance for 0 to 5 years prediction. And if you compare this to AI models, we have reported, and this circulates within the literature, higher AUC levels. And this is a narrative that AI outperforms the traditional model. However, these are rather moderate AUC level predictive models performances, and I think we have to have that in mind. So this is one of the first take home when we discuss and we look at AI in breast imaging, but that might be and certainly is true also in other applications. We should always look one level below. We should always go beyond the hype and responsibly interpret and read the results. And yes, obviously the interpretation is correct that these models are outperforming the classical models, but this is really still not enough for at least what I would expect for a groundbreaking improvement in prediction. And this translates and switches my perspective directly to the challenges what we face in a technical and also maybe sometimes in the clinical already application of breast cancer. One important thing, also I'm not talking here more technically, is, and this is most important, that we always have to have in mind that we are treating patients. This is, even a technical talk like this should be in the epicenter of the talk. We should always consider what our patients, women's attitudes are all about. And this is an important survey. There are many of these. This is very important. I just randomly selected. And generally, the authors report, well, women's attitudes are positive of AI. But if you do a little bit more closer look, a deep dive, if you may want to call that, then you have 16% negative response rate in terms of how they approach the use of AI in breast imaging, and 34, 1 out of 3 mixed to neutral. Obviously, this can be solved by education. Obviously, they are different and maybe more positive surveys, and this will likely change over the years. But I think we have to have in mind that women will always consider human interaction as crucial for their expectations with high quality care. And this obviously includes also breast imaging and breast screening in particular, where AI certainly will play a huge role clinically. I'm excited about the perspective and the upcoming clinical talk. This is just to prove that we are radiologists here, a classical mammography, CC, and MLO. CC is here, and here we do have the MLO. On the left breast is rather normal, and this is shown in a nice publication where AI detected, and I think quite obvious finding in the right dorsal parenchyma. And this finding is interesting because what the authors report in the study is actually not that AI detected a human oversight, because this lesion was not detected in the initial read. It was rated as negative in screening, and AI saw it. They did something different. What they did, they reported this finding, which was a false negative human reading finding, and a true positive AI reading, which is not a new finding actually, because there are lots of data that AI can sometimes outperform radiologists in screening and reading. The interesting finding here is, and this is something we have to have in mind if we talk about the new technology in AI, that it is kind of sold in new wineskin. It was sold that this patient obviously developed cancer in the screening interval because it was overlooked. The cancer was detected between the initial screening and the next screening, which we call in breast imaging interval cancer. And this was obviously present in this case. The reason why this was the case was that the human reader overlooked it and AI detected it. Nothing wrong about that. But I think what is a little bit critical to solve this obviously human error as a prediction of interval cancer in the meantime. I think this is something we should be cautious about when we read these papers. And once again, this is a fantastic group. This is a very good and excellent research, but sometimes we should take it easy and not overrate technology, because in my eyes, although formally this may call interval cancer, I think the AI did not predict here a cancer development over time, but it basically only detected a false negative in the initial screen. Very important here to be careful here to read the literature carefully and critically. And critically means in a constructive way. The commercial impact in AI obviously is everywhere. There's lots of vendor pressure. They have invested obviously a lot of time, a lot of effort. And this, in the business context, means also money. And obviously, they want to have some revenue for that. And the commercial impact is huge, because up to now, after years, if not a decade of investment into technology, there is not yet a broad reimbursement, at least in Germany and Europe, as far as I know, for breast screening AI applications. And this is why obviously vendors are also active to providing evidence. And this is fantastic. This is important. This is needed. This is something what we already know from oncology, pharmaceutical studies. But this brings us in a new position as breast imagers, as radiologists, because we have to kind of be more aware about the commercial impact. And the paper, I've been just discussing the past 3 to 4 minutes exactly about interval cancer detection rate on using an AI, was honestly, if you look closely, authored by many very good researchers, but these were employees of a commercial AI company. In this case, it was not about developing a new tool, a new AI. In this case, I would say as an editor, this is rightly, but this is an CE-labeled AI system just used for different use case, for different setup. And then I would say we should, as a radiology, be cautious to have too much vendor on the list. I think for the good of both, because an independent research paper, and this starts already with the lists of people involved, the lists of the authors, obviously, an independent paper is always of higher scientific quality, both for the company and also for the authors themselves. This is something we are, this is at least my impression, not yet quite enough aware. And this is something which comes new in the breast imaging AI world, because we are entering now in a different era of radiology. And you may wonder, is this just my personal impression? Is this just something of a critical thinker who just wants to highlight some stuff? Well, this is actually not at all the case. There's a landmark paper summarizing the performance of AI studies in radiology. And this is a paper you all should read if you want to do a deep dive after this session. And one of the key messages, and this is just the graphical abstracts of this study, is that AI is at least as good, if not better, than radiologists. Obviously, there are statistical fluctuations, but I think this is something we can accept as a given at the current point. So this is the key message sold. But if you go into the context and the subtext, something which I said already in the beginning, I like to do very much, but I think it's not just my personal hobby. It's important for us when we are on the edge of using this technology in a way broader sense. We should look at the data. And then there is in a hidden table, but it's table number 3. There's a very detailed analysis, but there's a very important factor which is easily overlooked because it is a so busy table. What is this table showing you? Well, it shows you the role of the vendor and the performance of the radiologists and the AI. So if there is a study in this meta-analysis investigating the role of AI and the role of the radiologist and the performance of the given cohort, there was an interesting finding. If there was a vendor involved in the study, and if there's a study where no vendor was involved, AI performance was stable. There was no significant impact. So studies not involving vendors had the same performance of AI than studies with a vendor involvement. This is fantastic. This is to be expected. What was interesting, and this is statistically evident here, that radiologists performed significantly worse in those studies with involvement of AI vendors. And I think this is a very important aspect because this kind of inflates the measured benefits of AI in the study. And this is certainly an evidence of a commercial bias. I think we have to have that in mind, and we should be aware of that. Even if this recalls and requires a bit more reading than just a quick ChatGPT or LLM review of a paper. And then there are many other issues we can be aware. There is this so-called automation bias, something I'm sure Paola will highlight, and if not, we can certainly discuss it later on, but this is extremely important technically. We should also touch base on the liability issues which we will have when we technically implement AI in clinical practice, because responsibility always lies with physicians and must not be delegated to a technical system. But how can we solve this if we use AI as a triage system or even as a second reader? Then we do have the problem that the human involvement is lower. So we need QA tools, we need explainability tools, and this is something where we are not yet very good at. There is, if you want to do a deep dive, because you are mostly EUSOMIans here, I'm sure, into this, we do have a nice explainable AI section in EGR. And now you know why I did the disclosure at the beginning. The question is, what is the real workflow advantage of implementing AI into our workflow in breast imaging? There are unfortunately not yet many studies out there, but I just choose here a paper investigating the prospective effects of AI-based computer-aided detection for prostate imaging, prostate MR on a routine workflow. And here, this very question was changed and challenged and investigated, and it shows a very interesting workflow related conclusion, because the focus was here on real workflow, on technical reading time, technical assessment of workload, and stress of the radiologists. This is something what should be actually at the core of our assessment. And what the authors report here, there were no clear time saving after implementation and no reduction in perceived workload or stress. Well, we do not have data here for breast imaging, but I think this is a very important perspective which we should have in mind when we talk about a broad implementation of AI productivity. And this is, I think, a paper which we should all discuss later, because this is a fantastic piece by Christoph Acton, which you all know. He's an influencer in our field, and he shared his vision on AI productivity. And his key message is it will not benefit employed radiologists, which I think most of us are, because the AI-supported shorter reading times, which will most likely be the result of AI-enhanced screening, breast cancer screening with mammography, will not automatically be better for radiology. The saved time, the faster time, will be likely invested into a higher throughput. And according to Christoph, this could reduce the value of radiologist labor. This is clear. If you have more money on the market, you will have an inflation, and then the value of your currency will be reduced. And this is the radiologist labor. And he nicely shows, I really recommend you to read that in a short piece, that history shows that automation boosts efficiency while reduces labor share of outcome. So most productivity gains will not go therefore to employees, but to vendors, private equity firms, and to the system itself. I think this is something we have to have in mind. All right. So what are other technical things we can use beyond detection, classification, and deep learning? Well, obviously, we can use ChatGPT and all these other wonderful multi-language, large language models, for instance, to translate text into a structured report and vice versa, to familiarize and to simplify these texts. And this has shown a considerable potential, but I'm still a little bit concerned whether the black box nature of many of these is really usable, not to talk about the issue of data privacy and of the black box nature of many of these tools. And there's many more to discuss here. I do not want to use all the time, all my slides here, but just one humble, very basic, very standard, but helpful tool in breast imaging. And with this, I want to translate already to Paola's talk. We always and frequently have difficult cases like this. We have multiple informations, multiple features, multiple descriptors, and even in the latest BI-RADS, which is our standardized terminology, we do not have clear decision rules. 15 years ago, together with my colleague Pascal Balzer and friend, we developed a very easy, very humble, from a methodological point of view, a machine learning tool. You may also sell it as an AI tool. And this proved to be helpful and kind of combines distinct parameters in a very easy, really technology-wise, straightforward way. But it has been shown in this late systematic review meta-analysis that it works not only in our research setting, not only in our multicentric trials, but on a global scale in dozens of studies with a high accuracy. And this is the case also in this very example. So this was one of my modest AI lessons, which I want to use to conclude this talk, that transparent, reproducibility, and easy to reach AIs are super important and helpful. Broad validation is important. This can lead to strong radiology tools, like in this little toolbox, like this so-called Kaiser score. And black box should be left, and we should go to structured and open source So in a nutshell, my modest AI lesson was that simple methods can solve relevant clinical problems. So, dear colleagues, dear friends, wrap-up time. AI in breast cancer, clinical and technical perspective. We do have a lot of clinical needs. We do have a lot of actionable information at our hand, according to major research gap. We have a lot of technical bias we have to deal with. This is automation bias, calibration bias, certainly commercial bias, also publication bias. We have to think critically to address these challenges, which can be continued to ethical challenges, liability challenges, educational challenges. But I am super sure that if we will repeat this webinar in a couple of years, AI will have entered a clinical routine even more than it already has today. We already have, in the breast imaging community, created a huge level of evidence, and the future potential of this method is certainly significant. And I would like to thank you very much for having me here. Super excited to get your questions, and even more excited to hand over to Paola and her clinical talk, highlighting what we as breast imagers really need in our clinical practice. Thank you very much for having me.
Thank you, Dr. Dietzel, for your excellent lecture. It's very interesting. Now we will move to the second speaker, and I am honored to introduce Paola Klauser. Paola Klauser is an associate professor and head of female imaging at the Department of Biochemical Imaging and Image-Guided Therapy of University of Vienna. She studied at University of Udine, where completed her study in 2009. Since 2015, she is working first as a researcher and afterward as consultant at University of Vienna. She has been involved in several projects focused on diagnosis of breast cancer, in particular on contrast-enhanced imaging. She is currently editor-in-chief of 𝗖𝗎 into Imaging. She co-founder and former chair of Young Radiologists Committee of European Society of Breast Imaging. She has authored and co-authored more than 100 publications in peer-reviewed journals and 2 book chapters. So today Paola speaks about the use of AI in daily work of a radiology breast unit. Where are we? Please, Paola, 20 minutes for you.
Dear Anna-Rita, thank you very much for your introduction, for your very kind introduction. Thank you, Matthias, for your lecture. You really helped me getting into the topic from a more clinical perspective. So when we talk about applications of AI, I think it's important to underline that they can go beyond imaging, starting from information to the patients, using applications to identifying patients at risk, so help them with prevention, with scheduling of the examination, with keeping a correct documentation, helping us writing the reports with all the informations we need at end. There is also a part that I think it will be the one entering the fastest in our clinical work, which is actually exam acquisition and image quality. And there is a little bit of image interpretation that nevertheless will take most of my presentation, because actually this part regarding image acquisition and reconstruction, as well as the organizational part, well, the organizational part I will be happy when it's there. Regarding image acquisition and reconstruction, basically all the vendors are very heavily working on it. So in many centers, it's already available. The first studies are already out there. And the main thing in this case is that we get fastest acquisitions, which has a lot of positive aspects, starting with patient comforts, shorter exams, reduction of motion artifacts. The question of energy consumption that is highlighted in some study, I'm not really sure, because actually this reconstruction require also a lot of energy. So I'm not sure whether it's actually efficient in this direction, but it's for sure more pleasant for patients. And By this, I would like to highlight something that Matthias already mentioned. For sure, this might end up in having more volume and then less quality to our work. So that's a risk we always have to keep in mind also when we enthusiastically start using new sequences. The main risk that I see here is that these sequences might hallucinate, so might reconstruct something that is not there as the artifacts we know already, but in a manner that might be more difficult to recognize, and this is something we should really keep in mind when we introduce these sequences in our clinical practice. And I guess, again, as Matthias said, in a couple of years there will be a lot of literature on this too. Now, if we look at the interpretation task, which for sure is the more interesting for us, most of the applications that are already out there for us are mammography and tomosynthesis. Some are already used in some hospital and are focused on image quality in mammography. What this software do, basically they tell us, is the image quality good enough? Can we use this mammography for screening? What usually happens in clinical practice is mammography gets done. If the technician is really good, he or she recognizes the poor quality, repeats straight away. If not, the patient has to come back in screening for a repetition of the exam with an increase, of course, in the radiation dose because we do it once, with more time till the diagnosis and so on. This automated software basically guides the technicians to perform the exam correctly. The results are increasingly good. So they really help us maintaining a high quality in screening, also with less experienced radiographers. Breast density also already very much used. Basically nowadays, at least simpler systems are installed in all mammography devices. We can also have them in our workstation to automatically identify breast density. It can be helpful, is not 100% necessary. So the biggest studies on, for example, the DANCE trial, which analyzed the usefulness of MRI in dense breast, use an automated evaluation of breast density. But the work by Clemens Kaiser, very similar, also another former colleague of Matthias, actually used a simply evaluation of breast density and achieved the same results. So it can be helpful, not 100% necessary in our clinical work. What I do believe right now is getting out there and might, if we use it properly, become extremely important is AI in breast cancer screening. So how batch screening works in almost all European countries and worldwide in most of the countries is the patient comes in a bus, in a hospital, in whatever center, only the radiographers is there, collects a short anamnesis, does the mammography, the patient goes home, and either she gets a letter or a phone call with the results. These images are currently looked at by two readers separately. If both readers evaluate the exam is negative, goes back to screening. If positive, the patients get an appointment for further assessment. If it's discordant, there is a consensus reading between the two or with by a third radiologist. The problem here is that it's really a tiring work, and it takes a lot of time that we could use to communicate with the patient, to more participate actively in the clinical decision making, while actually the radiologist stays in front of the mammography by him or herself and goes simply through a lot of images and a lot of images. And as all repetitive tasks, it's influenced a lot by experience and by tiredness. So there are studies that showed, particularly for less experienced readers, towards the end of the day, they lose a lot more cancers. Also, there are not so many dedicated screening radiologists. There are not so many radiologists in general. Screening is an even a bigger problem. So often the level of experience is relatively low in the readers, which also means more cancers that are missed because the readers are simply less experienced. And now that some screening programs are introducing also tomosynthesis, this means a much higher workload with reading times that have almost doubled compared to mammography alone. So longer waiting lists, longer waiting times, more tiredness, risk of errors, and risk of delayed diagnosis. In this setting, the introduction of artificial intelligence is actually one of the best tools that we have. Matthias already mentioned what the status was in 2023. So a lot of retrospective studies, overall quality of the studies, average, could be improved, actually needed to be improved. Again, some bias favoring studies in which the vendors was actively involved. Now, but things have changed very fast after 2023. This is an example of how things work some years ago. As you can see here, the lesion is very visible. There are some suspicious calcifications, pleomorphic calcifications grouped. On the CC view, wonderfully, correctly centered, very clearly a cancer. On the MLO view, not really actually, because the cancer is not there, it's actually here. And this, of course, might create a little bit of uncertainty in the radiologist, and that was quite common some years ago. This is another example. Again, 89% risk of there being a cancer. This is a synthetic mammography. Pay attention. This is not a normal mammography. This is the synthetic mammography, which is also probably the reason why the computer overestimated this area. That didn't look particularly suspicious on tomo. On contrast mammography, absolutely negative. So we still had some wrong evaluations. We still had some false positives a few years ago. Now, since then, some prospective studies have been published. Matthias already mentions the 𝗲𝗲𝗄 trial. Then there was this inter-individual analysis also performed in Sweden. Since I'm in Sweden right now, this is from the Karolinska in Stockholm. This is from the Malmö area, so southern of Sweden. And what these studies showed, and what is very, very nicely summarized in this review article that was published last year, actually, is that nowadays we have the 𝗲𝗲𝗄 as single randomized clinical trial, but we have more and more prospective studies. In some places where AI has already been introduced, we have retrospective analysis of registry court, we have reader studies. So despite the heterogeneity, the amount of data out there starts to be quite relevant to help us making decision on what to do with AI. The current evidence is mostly based, the larger studies are made of commercial AI systems. This is a list of some of them. And what we see in this study are also different ways to use AI in our clinical practice, going from an AI-supported double reading, so with the reader actually knowing the information from the AI triage, so the AI simply tells you, okay, this is probably nothing, goes to one reader only, or telling you not absolutely negative, then it goes to normal double reading, single reader with AI, single reader with the second reader as AI, or standalone AI. So there is really heterogeneity also in the design of the study of how artificial intelligence is applied in screening. Looking at the overall results of this meta-analysis, we can see that irrespectively of how AI is used, the sensitivity and specificity is actually really good and comparable with an average reader. With an average to good screening reader, expert readers still tend to perform better with AI rather constantly in the study that evaluated this. We don't have reduction in specificity, which was shown in the earlier studies. We have rather either a stable or improvement in specificity and a reduction in recall rate. And all the studies that analyzed AI as a triage tool actually consistently confirm a reduction in the workload for screening radiologists up to 40%. So a significant reduction in workload without any reduction in the quality of the work, which, if you think about something that is really repetitive, is really tiring, it's actually very good news. Now, if we go a little bit more into details, there are some things that we should keep in mind when we want to use these tools in our clinical practice. So different systems tend to detect different kind of lesions. Some are better with calcification, some are better with distortion, some are better for masses, some are better in larger breasts, some are better in smaller breasts. It's highly related to where and how they were trained, but a little bit also on how the algorithm works. So this is something we should know when we decide to go for one algorithm rather than the other. They still have, though they are reducing both false positives and false negatives, and they are very prone to technical issues. So they are very prone in false categorized examination with a poor image quality, and that's also why it's so essential to pay attention to image quality in these cases. These are a couple of examples, again, from our clinical practice. A very easy case is, again, a calcification case. Pleomorphic calcifications, partially linear distribution, highly suspicious, might have been lost by the radiologist, especially at the end of the day, crystal clear for AI. This is another example. Again, here, the mammography on the MLO was actually a synthetic mammogram, not a real mammography. So highly likely these mistakes are also related to that, because actually this was evaluated as a low risk, 17. If we look at the 𝗂𝗧𝗧 trial, and the threshold for the second reader in 𝗂𝗧𝗧 trial is actually 10. So this mammography with trauma would have still been sent to the second reader. But per se, it's a low risk from the AI system. You can see the thickening in the tomosynthesis. You can see the highly suspicious lesion on ultrasound. This was an invasive ductal carcinoma. And actually, the risk is very low. So per se, this might have been discarded if the radiologist wouldn't have paid attention to that. This is another example, again, with another synthetic mammography, though a very nice one, still a synthetic mammogram. In this case, the AI system evaluated the mammography as absolute negative. You can see, though, in the tomosynthesis that this is a speculated lesion, highly suspicious, and you can see the multifocal cancer in MRI, very easy to detect when we use contrast. Now, the examples I'm giving you now are mostly with synthetic mammogram, just to bring out the point that all these softwares are currently being used in clinical practice also with synthetic mammograms, despite being trained mostly on mammographies. And that might also explain why we get so many mistakes in this case, though the vendors actually support their use also in synthetic mammograms. So we should really be careful on what the vendors say and make sure that we evaluate it also on our data. Matthias already mentioned the use of AI for a risk evaluation. In this case, we also have to consider the ethical component. So we might be getting better in evaluating the lifetime risk, but we also have to make sure when we use this model that we also have some suggestions to the patient. So we have to know if we have to put them in the high-risk group or if we have to put them in the intensified screening group. Should they do an MRI? So this is something critical about the studying evaluating risk. It's really nice to prove in a retrospective study that we are better at evaluating risk, but we should really tell the woman, look, your risk is higher, so you should do this type of screening instead of standard screening. And this is what the ScreenTrust MRI trial did, already mentioned. Basically, what they did is they used AI for short-term risk evaluation to identify the mammograms, so the patients undergoing screening mammography with a negative screening mammography, to evaluate the patient that, irrespectively of breast density, would actually need some additional examination. The initial results were published a couple of years ago. Actually, the final results, I know it's right now under review, so hopefully we will see the full results of this trial, which are extremely interesting by the end of the year. The cancer detection rate was extremely high, even higher than for the dense trials and the other trials in women with dense breasts, 64 per thousand. So actually, this is a very interesting use and a very interesting application of risk analysis. So look for subtle findings, look for density characteristics that actually hint that we might be losing something there, and help us to trigger more sensitive evaluations now rather than suggesting follow-up for which we don't have the evidence right now. If we look at the situation of what we can actually find in the available to buy out there, compared to 2024, there is an increase of a couple of CE certified systems for mammography and TOMO. But as you can see, the situation for ultrasound and MRI remain quite stable. This is also related to the fact that it's much easier to get a lot of the imaging data for mammography. It gets a bit more difficult when we are looking at ultrasound, less reproducible, or MRI, a lot more data to look at and a lot of less examination available for training. So there are some nice software that helps you reduce reading times, false positive for ultrasound, very similar also for MRI, but there is really nothing out there that we can really use in our clinical practice safely. Now, there are a couple of things that we should keep in mind when we want to start using AI systems. First of all, make sure on how they work in your own practice with their own data and calibrate them based on your own setting. I work, for example, in a setting in which even screening is never batch screening, is more opportunistic screening. And as I was showing you with my example, I have the very strong feeling that our risk is actually going more for false positive and risking underestimating stuff than the opposite in a batch screening. So you have to really learn what you need and make sure that you use it in a proper way. Also, Matthias mentioned it, taking into consideration the risk of automation bias. So believing too much the machine and kind of losing your expertise or your critical thinking on the images. It's also important to keep track of the performance over time, because an update of the AI system or an update on your device can actually completely change the performance. It was analyzed actually in a very interesting paper in which they actually showed that the recall rate skyrocketed every time that there was an update, either on the machine or on the system, on the AI system looking at the mammograms. So it's also very important to communicate very strictly together with the companies just to make sure that we avoid these issues. One thing that it's talked about when we talk about AI is cost efficiency, improving time for the patients, and so on. But actually, the cost of AI might be very high, might be very difficult to introduce in your own hospital and to make it work together with the IT system in your hospital. I can tell you that my boss is fighting with this since she works in Vienna since 2 years. So that the costs and the integration are really huge steps to start working with AI, and they're not very easy to move forward with in many centers. It's one of the centers. Then being critical about what you need to make sure that you are incentivizing properly in your clinical workflow. In this sense, this article was published in Radiology Artificial Intelligence a couple of years ago, but it's still very, very actual and very interesting. And I consider you to read if you are considering using some AI tools in your clinical practice. It's really very helpful, and it teaches you what to pay attention to. There is still many points that need more evidence. In opportunistic screening, as I was mentioning, regarding cost effectiveness, and regarding interval cancers, the MASAI trial produced some initial evidence, which is okay, in the sense that we are not reducing interval cancer rates when we are using AI, but we are also not increasing it, so that's good news. I would like to remind you, for those who don't do regularly breast, that actually the dense trial using MRI in dense breast proved a reduction in interval cancers. So indeed, we might have expected a little bit more than these numbers. Also, the type of cancers that we find are not, the interval cancers that we find are not very different. So highly likely we are not improving our screening methods when we are using AI. But if we are improving our productivities, and if we are reducing our workloads, it might still, and if we are improving for less experienced reader, this might still be of interest. So overall, I think if we think about our clinical practice, the first area in which AI is becoming reality is for sure in image acquisition and reconstruction, because right now, actually, most of our system have parts that are completely or partially AI-based. Looking at the more clinical work, I hope that the number of tools used for triaging and so on will increase, and also their efficiency will increase over time. If we look at image interpretation, artificial intelligence is actually already introduced in many clinical practice in opportunistic screening, and also in some countries inside or outside of study settings, also for screening, but there might be need a little bit more evidence of exactly how to use it, how it is more cost effective, and how it is actually improving the workflows. I do believe that it might help us to guide personalized screening. The Screen Trust trial is a study we should really look up to in this sense. The clinical applications for ultrasound and MRI are still limited. Just a couple of last points. When you are considering introducing AI in your clinical practice, really think a lot where you need it the most, and try to find a tool that really fits your need and in which you can communicate very well with the companies to solve any possible issues. Legal and ethical aspects, as well as cost effectiveness, I barely hint on that. There is still a lot of work to do in this sense, but we can discuss it in the questions. And with this, I thank you very much for your attention. It was also a bit long, but I hope it was interesting for you. And if you're interested in more breast imaging, there's a couple of upcoming courses in the next months. Thank you very much for your attention.
Thank you very much, Paola and Matthias. It was a great overview, and you actually completely touched upon different aspects in which I made notes of, okay, what are the challenges of the vendor? What are the infrastructural challenges? Even what you mentioned in the chat, Matthias, about the work-life balance. And one other thing for me as a resident, what I was also wondering is, what about the de-skilling part of the work for the residents, for example? What are your thoughts on that? Because I think within breast, the subspecialty breast imaging, AI is one of the leading tools.
I don't know if Matthias wants to start.
Yes.
Well, I think you referred for the skilling that the more you use AI, the more you lose the skill of knowing the real thing. And I think this is something also which kind of relates to automation bias and all these kind of biases which will, fill up books and volumes. And I think this is a real issue. I honestly cannot remember the mobile number of my wife for this very reason. I tried it hard. This is really a joke. I cannot remember it, but I still remember the phone numbers of my first friends in elementary school, because these days I had to remember it. So I think this is a real thing, and not only in my personal. This is a joke, an anecdote, but I think this is something how our brain works. I think this is a real risk. And this also translates to another bias. I think calibration bias is also something, right? And all these algorithms are trained on data. This is why I kind of digged in a little bit more. So if data A is different from data B, so it's data of the 𝗲𝗲 trial as a study is used to a different setting. Let's say assessment in Paola in Vienna is a different clinical setting than these patients seen for screening. This will also kind of lead to a different assessment, and this needs for calibration. I think there's a whole bunch of of topics, but let's go back to de-skilling. What's your take on this, Paula?
Actually,
Can you remember your phone numbers?
My sisters.
Oh, you're good. I cannot. Okay.
So basically, there are also some interesting studies that use the AI to train residents. So kind of using it to train your skills in the beginning. It's complex. It's really complex, and it depends on how you use it, because of course, if AI is wrong and you don't realize it, then you will be learning something wrong. But you can actually really see it, especially in the beginning. We should really do that. So use it as a tool to say, oh, okay, AI is showing me this. Is this correct? Why is it correct? Why is it not correct? So that you kind of use it for yourself to train your own skills. It's like a bit when tomosynthesis was introduced, we didn't have synthetic in the beginning. And then I would look at the tomo, very easy lesion to find. I will go back to the mammogram and say, could have seen it also on the mammogram. So you can still use it like this. I think you have to learn to be very critical on what you are seeing. But this is true also after 10 years of experience. You know, if you know that your tool works, you tend to be over-reliant on this tool.
That's indeed, I think, one of the major points within AI in general is the awareness of its limitations and risks. And that depends I guess also of the tool in how far we can see that. I mean, also Matthias shortly said about, and I think Paola, you also, about the stepping away from that black box feeling. And I think another thing is that we do remain as the responsible decision makers. So that makes it also a bit difficult with the ethical part as well, right? Regarding the patient, in which you showed within the research as well, that the patient in general are okay with it. Like, how do you think this will be in the future? Like, how the implementation of will the patient be able to say, like, okay, I just only want the radiologist to look at my breast imaging, or do you think there will be a path like that?
If the opposite.
Yeah.
If the opposite, but actually, I'm not really sure we will ever get to a point in which we'll let the computer do everything. I mean, it's like with self-driving cars. The level of error that we accept from self-driving cars is not the level of errors that we accept from the average driver. And I think that will be the same also with AI. So there will always be a legislation that requires us to double check everything, as I think it's supposed to be, especially in the medical field. But I do think that the main issue with the patients is actually data protection. So even the one that are skeptical, they are not skeptical because of the tool per se. They are skeptical of, what are you doing with my data?
Yeah.
At least in my experience.
Yeah.
I think key here is how to measure quality, right? What is quality, right? One obviously is this accuracy thing, right? But what is a quality assessment, a QA chain actually? And as long as you don't have this rock solid, it's difficult to say it's better or it is safe, right? So this is a technical discussion, also a philosophical discussion. And then what, as Paola said, what level of quality do we accept, right?
I really
I'm not a pharmaceutical guy, but if I recall my pharmaceutical lectures at medical school, it's been quite a while. But I think one of the key things, and you guys in the audience, please correct me if I'm wrong, because I'm not an expert here, but I think one of the key reasons to put a new drug on the market is A, it's safe. So you have to define the safety, but B, it has to be better, right, than the already proven drug on the market. So it has to be better. It has to prove some benefit. Just doing the same thing with a different label, with a different technology is not a good idea. And the reason for this is obviously the good old-fashioned thing, which is running safe for years, which already has been evaluated for many decades, is like intrinsically safer than the new thing where always surprises might happen. So this also is, I think, something we have to have in mind. And this, I think, is also what patients would expect, that this thing is doing better, right? And if it's not, I think they will stick to the old-fashioned film reading. And I think that's important to have in mind.
I also really liked that you mentioned the word calibration. Today I, by coincidence, gave a talk about T2 mapping in cardiac MRI. And that was the same thing. Okay, we can do T2 mapping. It's vendor-specific, MRI scanner-specific, sequence-specific, even related to age and gender. But if you change those parameters, you have to do your quality check again. You cannot rely on the reference values that you calculated for that specific MRI scanner or vendor. We also have a question in the Q&A box.
In the chat, yes.
Would you like to take that upon you, Anna-Rita?
Okay. In the chat, thank you for two very interesting talks. I was especially pleased about the reference of the 𝗲𝗰𝗂 et al. Showing model drive with the upgrade image processing software. I believe this is a big challenge. Can you speak a bit more about your opinion on how to overcome model drift in clinical implementation of AI? It's a difficult question.
I mean, that's obviously a topic of its own, right, Paola? And this is certainly also a topic why we need calibration, right? Because if you measure a drift, then you always have to have some reference line, and this is what calibration is all about, or the good old gold standard. So we should always continuously monitor stuff. We do define audit, obviously, to measure that. We should define some escalation pathway. So this is all about calibration, as you said, Pinar, nicely. It's like your T2 mapping in your cardiac. It's the same here. It's we have all, and if there are deviation, if there are issues, we have to also define responsibilities on the vendor side, but also on our side. So I think this is good for the next year's edition. But I think this is, the most interesting, but I think also not the most sexy, if I may say so, part. Because without calibration, without knowing what to do if it's going wrong, we got a problem. And if we don't even measure it, if we don't have a textbook how to measure it, then we have a model drift, and we don't really know whether it's going on. I was just talking to a breast imager in preparation of this talk. I will stop in a second. And they are thinking about implementing really this in a really broad sense, right? In Germany is really very well regulated, and they are thinking about getting like a reference, national-wide database. And I think this would be cool, a first start point to do this. But once again, this is a huge topic, an ocean of topics, actually.
What you mentioned, indeed, it touches upon so many different parts, like also epidemiology. It reminded me when we started talking about the calibration part and the biases of the PROBAS paper of Carl Moens. I mean, that's also something that we quickly, forget, actually, when talking about the AI tools, implementation, what are the results, etc. But indeed, to be aware of the biases that we encounter consciously, but also unconsciously. I think that's also a good thing to mention from an epidemiological perspective.
Thank you, Matthias, for starting answering the question. So I'd actually had the time to think about an answer. No, the thing is that there are people working on it. If you think about it, between all of the projects, I think many of us are involved in some way or the other with the EUSOMII project. And one of the things that the EUSOMII aims to do is building a data set that you can use to kind of threshold your systems, right? So regulations, people in the EU Commission are working on regulations on how to do that. The paper I mentioned from ESR together with the RSNA, ACR and so on also mention that you should make sure to check how the systems are working. So there are a lot of different groups, people, associations, regulators that are actually working, trying to build a framework to make sure that we do not overlook these issues, because it will be, some of them probably we will be able to check in our clinical practice, and like as we see that the ultrasound machine is not working, or that the MRI makes the images weird, probably some of them we will catch them, but for some of them we will need some frameworks. So there are a lot of people actually already working on it, and I think we will see it coming out either as laws or as research articles, recommendations and guidelines also in the next years.
Thank you very much, Paola, for this recap and enlightening us with the research on progress on this topic. I think looking at the time, I would definitely like to close this great webinar. It was also another topic for me that you encountered during conferences, etc., but not really dive into it this much with the overview of the great technical part and the research and the clinical part that you provided us with, Matthias and Paola. Thank you very much again for joining us and for answering the great questions. This was also the last webinar of this series for this year. From summer onwards, we're planning next webinar series. So please keep our website and our social media. Keep a look at that, and we will update you with our next series soon. Thank you again very much. Do you want to have a final say, Anna-Rita?
Thank you very much to both speakers for your excellent lecture, very interesting. And I think that this is the time. And thank you also to everyone connected in this webinar. And we will in the next year for the next webinar series. And bye-bye to everyone.
Thank you very much. Bye.
Thank you very much.
Bye.
And in case if you want to do a deep dive, come to Maastricht, not too far away.
I was already invited during the ECR by the 𝗬𝗶𝗃 members. And
okay.
Thank you.
Great. Thanks for having us.
Thank you very much, everyone.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye.